We offer 24-hour care in a hospital. It is a secure environment. It's the only medium secure unit in the country which works with personality disordered offenders.
There's very little treatment on offer for such individuals.
We have to offer these people an opportunity to give them a chance to change their lives, to educate them, to treat them.
I've changed in I've grown up. I'm more laid back.
They treat you a bit more like a human being. Don't treat you like animals.
It's extremely challenging. There's an expectation that patients engage fully into the programme.
It's even stricter than some prisons. There's certainly more rules and regulations and more things that our patients here have to comply with.
According to a 1998 survey, around 2/3 of UK prisoners have personality disorders. But until recently, only a handful were actually given any specific help with this problem before being released back into the community. Now, government policy is changing, and despite criticism, it has brought a clearer focus on the causes of offending behaviour and a welcome emphasis on providing therapeutic treatment. Arnold Lodge in Leicester is a medium-secure psychiatric unit with 56 legally detained mentally disordered offenders. Within Arnold Lodge is a self-contained personality disorder treatment unit, or PDU, with a maximum of 12 male patients. This is associated with the Leicester Warwick Medical School's Division of Forensic Mental Health. Staff on the PDU are very tightly integrated across the disciplines, with nurses, psychologists, occupational therapists, educators and psychiatrists working together as a single clinical team. Treatment is tailored to the clinical needs of each individual, helping him to learn to cope with challenging situations and equipping him with skills and education to help him avoid reoffending when he returns to the community.
I suppose a lot of the treatments we offer aren't that different to what's offered in other mental health units, but we do it in a very focused way.
It's probably one of the only wards I've ever worked on where we actually work as a multidisciplinary team.
I think it's very important that people feel that if they have got good ideas, that they're listened to, and that those ideas are enabled to be put into practice.
Team members need support from each other as well. The work can be very difficult and stressful, so a good team is essential to treatment programmes such as this.
It gives a different perspective from different professions, and it's important to have that overall view.
The pre-admission evaluation at the PDU is one of the keys to successful treatment. Referrals are rigorously assessed for their potential treatability. Each referral is independently evaluated by PDU staff from the nursing team, from psychiatry and from psychology. The whole clinical team take part in the final decision to admit a new patient. To gain admission, all patients must have a personality disorder. They must be treatable and motivated to change, and they must require conditions of medium security. Those with a history of sexually sadistic offending and those with psychosis are excluded. The patient's first 3 months on the PDU is the admission phase, when further work is done to identify individual needs and to plan treatment.
Do you find that you feel the need to, say, go into a room and be quite loud because everybody's being quiet?
This includes a series of psychoeducational sessions which clarifies the individual's personality difficulties and develops a collaborative approach between the patient and the staff, a therapeutic alliance.
Depends who it is though, depends what they say.
At the end of the 3 months, the clinical team come together again with formal presentations from different disciplines to decide whether to accept the patient onto the treatment phase of the programme. An offer of treatment is then made to the patient, who may decide to accept or reject it. Indeed, patients are free to leave the PDU at any time and go back to the institution from which they were referred.
The minimum expectation from patients is that they genuinely participate in the treatments.
When they come to us, they have to embrace our structure, they have to embrace what we do.
They've got to show a willingness to reflect on their own behaviour. They've got to show that they're interested in making a difference.
I think we have the expectation that people will behave in a civil manner to one another, and I think that's quite a reasonable expectation to have. And it does surprise me that in many places that I go to, that isn't the kind of expectation that people have of their residents.
Planning and organising the week is seen as a vital part of the treatment here, giving structure to the patients' lives. Each patient has a daily timetabled plan of activities, Monday to Friday, 8 a.m. to 6 p.m, negotiated each morning with a member of staff. PDU staff run a tight ship. Patients are expected to conform to the rules of the unit and accept responsibility for their behaviour. There's zero tolerance of physical violence and of illicit drug taking, and patients have to engage constructively with their therapeutic programmes. Individual patient progress is closely monitored. Even in day-to-day life outside the timetabled treatment sessions, the ward staff are primed to look out for specific behaviours from each patient. Meanwhile, patients keep diaries of their own feelings, such as anger, which they're learning to recognise and control. They keep a note of how they've responded to these emotions. Did they manage to control the anger, or did they act aggressively?
There's quite a common theme with this group of individuals. They come from a very chaotic background.
Very poor at planning, having structured days, not very good at goal setting.
Very often from dysfunctional families.
No significant work or education history.
The consistency we offer here for many is the first time they've ever had that sort of life.
We don't accept them sort of taking days off sick, opting out, spending lots of time in the room when they should be actually in the programme.
Now, typically our patients, when they first come here, find that quite oppressive. They bulk at it.
You've got to constantly work to keep yourself here. I mean, sometimes it pisses me off, but I can see the logic behind it.
We're trying to sort of mirror normal life, if you like. We have to get up and plan our days, and it's something we're trying to get the patients up on the PDU to do from a very early part of their stay.
The idea of structure starts to be quite upholding for our patients. They begin to feel more safe and less chaotic in themselves.
The difficulties these patients face fall into two categories. Patients are either not able to do something, a can't problem, or they don't wish to do something, a won't problem. For example, this man can't accept being told no. He simply doesn't have the social skills to negotiate, and so he resorts to aggression or violence. While this patient won't negotiate, although he's quite capable of doing so. When he's refused a request, he retreats to his room and sulks, and sometimes he's found that he can get what he wants through this sort of behaviour.
It's been alright. I mean, this week's not been good though because I've not been getting up.
Won't do patients are addressed mainly by individual psychotherapy to meet their specific needs. Here the PDU is adopting the responsivity principle. Successful treatment requires staff to provide what patients need when they need it. The things that patients can't do are tackled by a programme of cognitive behavioural therapy, made up of core training in social problem solving, with anger management and substance misuse treatments for those who need them.
Can you tell us what the problem is then?
Yeah, well, I wanted to watch this film, and it was on at 9 o'clock, right? And football was on. And
The cognitive behavioural treatment programmes are based on some key principles. Patients are viewed as rational people who behave as they do for a reason.
I fucking hate it. I hate it when people say that I can't have something or when I can't do anything.
They're helped to devise alternative ways of achieving their goals, changing their problem behaviours mainly through recognising their own powers of self-control.
At school and, just over stupid things.
Treatments are active, participatory and engaging. The patients actually manage their own treatment. They're taught to become personal scientists, keeping the diaries of their thoughts, feelings and actions, studying their own behaviour, experimenting with new ways of control, and evaluating what works for them.
Because my mum and dad were shit to me and they treated me like I was a punch bag.
Finally, all aspects of the treatment are integrated with the regime on the PDU. So nurses help participants to implement the lessons learned in therapy as real problems arise on the ward. Occupational therapists teach the skills necessary for participants to carry out their problem-solving action plans. Criminogenic therapy sessions focus on changing criminal thinking to prevent reoffending. Educational sessions help to improve self-esteem along with improving the patient's future prospects. Each component of treatment is based on the same psychological principles so that each one augments the others.
I think there's a mystique about how do we treat personality disordered patients. What we actually do on a day-to-day basis perhaps isn't that different to what other professionals do.
One of the main focuses of our treatment is to help the individual to retrain their own lives.
These patients are very impulsive, they're very concrete in their thinking, they're antisocial in their thinking, and what we want them to do is basically stop and think. Don't react. If you're confronted with a problem, with an issue, any difficulty, think about it. Weigh up different options, pick the best option for you, which is going to keep you out of trouble and it's going to get you what you want.
The social problem-solving programme is called Stop and Think.
First one was
get another television.
Yeah.
Was that a do you think
No,
that's
it
something
didn't
you
work.
can do?
It's not going to work. Negatives outweigh the positives.
Treatment is based around the fact that personality disordered offenders are impulsive. They haven't learned to think about their behaviour and its consequences. They simply react emotionally to life's frustrations.
No, I didn't. No.
Group members are taught to work on their problems systematically using 6 key questions.
People identify what the bad feelings are and take that as a prompt that they need to do something. The patients identify what their problem is. They identify what goals they want to achieve, so they have something to aim for. They develop numerous options, which they then consider the pros and cons of, and then develop a plan. And that's something all of us do every single day. That's something I do to get to work.
It's literally an opportunity to slow them down so that they might start to understand their behaviour better.
So we are teaching them these new skills with the hope that they will become automatic so that in future they will be more rational in their approach to solving problems.
There's one thing that knowing something's bad, yeah? But if someone in authority is telling you that it's bad, it's not as good as when you sit down yourself, yeah, and actually work it out for yourself.
Now and again we get a new patient who comes in and says, well, this doesn't work, it doesn't work for me, and I don't have to say anything because the other lads in the group will say, well, actually it does work, it's worked for us, and you've got to give it a chance, you've got to work with it, you've got to put a lot of effort into it, and you will get the rewards.
Stop and Think is a core element of treatment for all residents at Arnold Lodge PDU. And its problem-solving approach forms an important part of the other 2 cognitive behavioural programmes that are available for those who need them.
Yeah, when I got down here, that I think the main influence early on was my dad.
Controlling substance use teaches people to control the triggers to substance use and to be prepared for risky situations they'll meet in the future.
This was like 11 years old or whatever.
They need to change their whole lifestyle, moving away from heavy drinking and drug use. This is preparation for life in the community, where they'll have access to drink and drugs.
Yeah, I got really angry on Wednesday.
And what happened?
I wanted to have a game of pool.
In the Controlling Angry Aggression part of the programme, participants are taught that anger is a normal emotion which can often be positive. It becomes a problem when it's bottled up or when it's expressed through aggression. The programme takes a systems approach to anger and violence. A trigger, such as a frustration, an insult or a perceived injustice, is processed by the individual in the light of his or her past experience. This sparks anger only in people who perceive the trigger as a threat. In turn, angry feelings will spark violence only in those who are used to violence as a way of dealing with a perceived threat.
I suppose I thought about the consequences,
So patients learn to recognise their angry feelings and express them in a controlled manner. They learn to reduce their anger triggers, alter their hostile views of the world, relax and learn non-aggressive ways of behaving.
And I went back to my room and just did a bit of breathing and stuff and a bit of relaxation.
So in here, people don't have to put a facade on, they don't have to be the hard prisoner, they don't have to be the person who hides in their cell worried about what was going to happen, or scared that they look vulnerable. Very quickly here, people figure out that it's an environment in which they're encouraged and respected for telling the truth about the things which happened in their lives. People become very open about their pain and their anxieties, the nightmares they might have.
So we want to give people the skills to actually, in the future, they've got different choices to make. So maybe they go down the right road and not the wrong road to reoffending and chaotic lifestyles again.
After the 15-month treatment phase comes the final 6-month pre-discharge phase. In many ways, this is the most challenging stage of the process. It involves a lot of effort in working with the through care agencies and managing the discharge effectively. Patients have to deal with ending their relationship with other residents and staff. For many, this is one of only a few good relationships they've ever experienced. On the other hand, other patients are bound to be envious of those who are about to be released, and this causes tensions on the ward.
I think it's very important really that you have throughput in a system like this. I think there is a time when people can benefit, but that has a kind of natural history, and after, I think, 18 months they've probably got as much out of this system as they're likely to get, and it's time for them then to move on.
In prison, I withdrew into myself and just kept myself to myself.
In other hospitals, on other wards, like, you just sort of coast along, and as long as you keep out of trouble and, you know, do what you got to do, then nobody mentions personality disorders.
It's very much a self-directed program at the end of the day, because they only get out what they put in effectively. It's down to them to put the work in.
It's not just about what happens in specific treatment sessions 10 till 12. We're very, very, perhaps even more interested in what happens in informal time on the ward as well.
They can get under your skin a bit. So it's quite important that you have a lot of individual supervision, group supervision, so that's quite essential really to working with these people.
It's great that the staff on the ward get the opportunity to have the level of training that we're able to give, and it's good to see staff achieving as well and becoming highly skilled in a lot of quite unique programmes.
Arnold Lodge PDU is seen as a successful treatment unit, but what's going on here is not rocket science. Its strength relies on selecting treatable patients and on the discipline and structured timetable of the patient regime. The treatment programmes can flourish because staff across all disciplines work as one team, constantly reinforcing what the patients are learning through all the different forms of therapy. Pilot studies show that both the problem-solving and controlling angry aggression programmes lead to immediate improvements in thinking styles and behaviour. The real question is whether the gains made on the PDU are sustained once patients leave and return to prison or are released back into the community.
The Stop and Think programme, I would like to think, would tool them up in a way that they could deal with everyday issues, simple ones, difficult ones, with keeping themselves safe without behaving in a dangerous manner.
And at the end of the day, that's what we're about. We want people to be mindful of themselves. We want people to be skilled up for life. And we want people not to offend and harm other people.
Seriously, I think everybody should come here and spend 2 years.
To me, I think there should be more of these places, you know, more PDUs, you know.
I just feel that, you know, when I go out, I can deal with all the stuff that I know is going to hit me again.
Something that is very important is support for patients when they move on. I think if they have good support networks, then the likelihood of what's been learnt here of being more effective is going to be increased.
The proof of the pudding will be somewhere down the line once enough patients have been discharged and been at liberty to either succeed or not.
But we certainly know by not giving them treatment that they're not going to change. So hopefully if their experience here might do them good, might keep them out of trouble.